Okay, here we go then. So we had a little week break last week. I had a little family holiday. Summer here in England seems to have calmed down, and I got a big jumper on again. So I hope you are still enjoying all your summer. Let's see if we can do this. So we are today, 21st of August. Imagine that. We are pretty much 3 months in our talks now, our lunchtime talks. And this week we're going to talk and give you a quick update on leptospirosis. We're going to, just as a brief overview, do a bit what, how, and why we're talking about lepto. Um, we're going to briefly talk through the more common presentations. I mean, this talk is mainly about diagnosis and treatment. If at the end you want me to do another talk about presentations, let me know, but we're trying to fit it in a half an hour. So let's go through it. The poll we ran this week on LinkedIn, and thank you, just before I started the talk, about 79 people, hopefully some of you have responded to the poll. And the question was, well, what do your patients present with lepto? Because it is such a variable disease. Now, fairly commonly, most dogs that we suspect of lepto have presented either with kidney or liver problems together. Bleeding issues, obviously less common issue that we potentially recognize, but definitely out there. And as we're going to go through this week, there's other problems that maybe we underestimate how many dogs with lepto are out there. And if you think at how many dogs we treat with potentiated amoxicillin, for potentially some of us non-specific reasons, some of these dogs will get better anyway. So there's definitely a feeling that we're underestimating how much lepto there is out there. Now, to put it in perspective, this is a zoonotic disease. Not saying that many dogs will give it to humans, that is very unlikely, but it's still a disease that affects humans. I'm not sure who's not muted, but if you could mute yourself, that would be great. And they're talking these days that up to 1 million people get diagnosed with lepto a year, and that probably is still an underestimation. It is a disease that is commonly very flu-like in people, but it can become very severe, similar as in dogs. So it is important that we recognize, and they can be almost a marker of aerial disease. So it's important that we look out for these cases. For the 18% of people that have told me I don't see any cases, I think either you've been very new in practice or you might have under-recognized cases. Now, it's not that it's such a high prevalence as we know of. Definitely UK-wise, there was a study in 2014 and they probably estimated that people in general practice, on average, each vet would see at least one case a year. Obviously, working in referral practice, the cases that don't resolve, we might see more often, or the more obscure cases. So I am aware that we probably see quite a few more cases. But it's still important to be aware what you're looking out for. So when they come along, you can recognize them. Okay, so as a quick overview, leptospirosis, they're these spirally bacteria that we call spirochetes. I'm not going to say that word anymore, it's hard enough. And the main infection is driven from when we get infected from a maintenance host. Okay. Now, these maintenance hosts can contaminate the environment and indirectly infect us, and we'll talk through that. But there needs to be a maintenance host in the environment. Okay. The incidental host are the patients that we see, be it humans, dogs, cats. When we see them being poorly, they are very unlikely to spread the disease on. But we know that these bacteria, obviously, they in the maintenance host, they live within the kidney tissues, within the tubules, and they have an intermittent shedding through the urine, which will then contaminate the environment. Now, these bacteria can live in moisture very well, be it biofilms or wet soil or water. So it doesn't have to be a lake, it doesn't have to be a river, it doesn't even have to be a puddle. Mud, wet soil, they can live in there for weeks to months, okay? They do die off at freezing temperatures, but even then, if you think of wet soil that gets frozen, the center doesn't always get frozen, so it can still remain in there. Now, there's more than 300 serovars, and people have grouped this on and off in different ways, and that probably is clinically not that relevant to you guys. So, but if you look at the most pathogenic serovirus that we recognize in our patients, these are the 8 most common ones. And we'll talk about the vaccine later because some of these we will find back in the vaccine. Oh, so what you can see here is the reservoir host, and then the incidental host is the patient one, so the sick one. The reservoir host overall is a very well patient, or not patient, it's a very well animal. But they keep shedding these bacteria intermittently, and that can go on forever and ever. Now, the main one that we are worried about, definitely from a human perspective and from a dog and cat, is rodents. And we know that about, on average, 30% of the rodents in the world are infected. But in some areas, that can go up to 80% of the rodents. Okay, and we know definitely that rodents are everywhere. So if we then how do we get it from the carrier host to our patients, or how do they get infected? So that can be the direct by the urine. It can go via the venereal route or transplacenta if mum was infected. It can go by direct contact of bite wounds with rodents, or say cats, dogs hunting for them, definitely can happen. Or ingestion of infected organ or tissues, so eating dead animals, it's there. Or it can happen indirectly by exposure of the contaminated water, soil, or food. Okay, so we do know that there is overall a higher incidence at periods or areas that have a higher rainfall. We know that definitely in the UK, hunting dogs and America, hunting dogs and young male dogs are more likely to get infected. And we know that dogs with a rural access to lakes or rivers are more at risk. However, we know that any dog is at risk for leptospirosis, and that doesn't matter because we know that there's rodents in towns. We know that any dog can get infected. So don't ever rule it out when they are presenting on that basis. So we'll talk a little bit of the effect of vaccination, and we'll regain the vaccination bit at the end. But so when you get infected or you come in contact with the organism in the environment, the way you get infected is either through intact mucosa or through abrased or really softened in water skin or wounds. Okay, that's how the bacteria get into your blood. What happens then depends on what your immune system is doing. So for the dogs that are well vaccinated, they will have a high antibody titer. Okay, that will eliminate bacteria and you won't have any clinical signs. Okay, if that titer is watering down, weaning down, or dogs that previously have infected and eventually the antibodies go away, so they have an intermediate antibody titer, they might still have a shortened bacteremic phase and they might still have milder signs. We definitely see these dogs presenting, but these are the dogs that often will survive, okay, because then they will eliminate the organism from the kidneys. Now, the dogs that are not vaccinated and have a lower absent antibody titer, you get quite a heavy bacteremic phase. So the bacteria multiply in the blood, and then after a while will start invading organs and cause problems. Okay, so that is where vaccination, that initial stage very much depends on what's going to happen in what your antibodies will be doing. So we said bacteria come into the body. You then got a variable incubation period, can be anything up to 2 weeks. Okay, and then you'll get the first, often as specific phase. So there'll be a febrile period. Some of these dogs could present with polydipsia, polyuria, or just plainly unwell dogs. They're lethargic, they don't want to eat, they might have some vomiting, but very unspecific signs. Okay, and after that initial phase, you will then get the bacteria to disseminate and settle into the organs and start causing damage there. But you might start getting more specific or still non-specific issues there, really. So when we diagnose these dogs and you look back what they presented with, again, in that table on the left, they're the most common clinical symptoms. And as you go through them, these are problems we see on a daily basis for things that often aren't leptospirosis, okay? But it can be leptospirosis. But they're very hard to identify at those stages because these things just happen. The one that is maybe more specific is a jaundice and the acute dyspnea. But there's other things that can cause it as well. But there's also less common problems that have been reported and linked with leptospirosis and conjunctivitis, uveitis, meningitis, cardiomyopathy. There's lots and lots of other problems. Okay. And that is similar with the blood changes that we can find if we do take blood on these animals. The hematology is unspecific. They've got an infectious disease. You often get a leukocytosis, although initially, because they're using so many white blood cells, they might be leukopenic. What maybe is a little bit more unique is thrombocytopenia. It's a fairly common finding. Up to 2/3 of the patients will have some thrombocytopenia. Okay. Biochemistry depends a little bit on what organ they're invading and affecting. But we're talking the azotemia with the kidney injury. We're talking liver enzyme activities being increased when we have liver invasion. And often, we had a whole talk about this a couple of weeks ago, but often we will see that the alk phos will be far more elevated than the ALT. So it's a cholestatic pattern. The reason it happens is it makes the bile leak out of the biliary caniculi and damage the liver. So generally you get a cholestatic pattern with leptospirosis and the high bilirubin. Often because they're highly inflammatory diseases, you get slightly low albumin. So and then you can get coagulation problems. Now, these can be prolonged PT-APTT, this can be DIC, this can be hypercoagulable state. There's a variable one, so it's very hard to pinpoint what exactly. And then we get the urinary changes because we often check urine. So often these dogs will be isosteniuric because the renal tubules get invaded. They might well be proteinuric and pyuric or hematuric. They might have one of the more things, definitely what we come back to when to suspect lepto is if you find a glucosuria patient without hyperglycemia, that should be on your list. And then because of the tubular damage, you might get some casts on your urinalysis. I'm briefly going to talk about pulmonary hemorrhagic syndrome, which is something we start recognizing more. And again, this is probably one of the presentations that before was very rarely linked to lepto. But we now know if you take radiographs on dogs with lepto, that about 60% of the dogs will have changes on their radiographs. And these can progress. So often what these dogs will develop is microscopic bleeding in their alveoli, might be interstitial pattern initially, but that can then progress to an alveolar pattern. Now, this can happen very acutely and very suddenly, and this has a very high mortality associated with it. Okay. Some of these dogs will be coughing or bringing the blood up through their nose, but not all of them. But the dyspnea, the tachypnea is definitely a marker, and you should be taking radiographs because that could worsen quite quickly. Rest of the X-rays are not really that specific. As you can imagine, these are very much soft tissue injuries that the bacteria are causing. So we very rarely see other major changes on X-rays. But ultrasound, if you're good at it, then you can definitely find out. So what these bacteria cause is swelling of the organs that they're affecting. So if it's the kidneys, we're going to find large kidneys. We're going to find changes in the echogenicity of the areas and a reduced corticomedullary definition. Okay, might be a slight bit of fluid around your kidneys, but again, we often see that with dogs with acute kidney injury for different reasons. When it is liver, again, the liver will often be large and it will be slightly hypoechogenicity diffusely. You might get a thickened gallbladder. Okay. And then your gastric wall might be thickened. We do see some of these dogs presenting with hemorrhagic vomiting and diarrhea. And again, not everybody will test them for lepto, but unless you test, you won't know. And if you think about it, what a lot of these, what we do, if these dogs are really hemorrhagic gastroenteritis, we put them on antibiotics. So some of these will get better anyway. Splenomegaly, we can see, and sometimes the abdominal lymph nodes can be up. So how do we diagnose these patients? Let's talk through that. How can we diagnose them and when should we be picking what tests? So I think first rule, you need to be suspicious of lepto, otherwise you won't test for it. And if you don't test for it, you won't find it. So to have a profound diagnosis, you need to first have a healthy suspicion. And I'll talk you through what the current guidelines are to have a healthy suspicion of what patient we need to be looking at. But in general, any dog evaluated for acute kidney injury, especially if you don't have any obvious reason present, and if they have also associated liver dysfunction or lung signs. Same cats with acute kidney injury and signs of suggestive of systemic infection should be checked. Unless, again, obviously keep in mind that other things can cause it, but you should check for it. So our suspicion, when we talk about talking through the criteria that have been put up, and all this you can find back in the ACVIM guidelines of 2023. But when we're talking about a probable case or a confirmed case, okay, both of them, it's a combination of clinical criteria and lab criteria. So that is important because when we go to the testing, we will see that we will get some positive results on dogs that are vaccinated or had a subclinical infection before. That is not necessarily the cause today of the problem. So we need to be sure that the patients to diagnose a probable or confirmed case that it has some clinical criteria fitting with it and one or more lab criteria that either supportive or confirming lepto. So let's talk through the clinical criteria. So when people said the clinical criteria need to be fulfilled, that is the onset of systemic illness over the last 2 weeks. And that can be with or without clinical signs suggestive of lepto. So that can be with or without gastrointestinal signs, respiratory signs, urinary signs, because they're so wide, people haven't pinpointed that you need to have certain signs, okay? And in addition, you need to have 2 or more of the following abnormalities of your investigation. So investigations being urine, so glucosuria while your blood glucose is normal. Could be blood changes. So if we talk hematology, neutrophilic leukocytosis, thrombocytopenia, we could have biochemistry changes of AKI, hepatopathy, pancreatitis, CK, so creatine kinase, because we can get myositis. We could have radiographs of pulmonary changes, might be in there, or we can have the ultrasound findings or ECGs. So leptospirosis can also cause a cardiomyopathy. You might find an increased serum troponin or some cardiac arrhythmias. So you don't need to have them all, but you want to have 2 or more together with systemic illness onset of 2 weeks. Okay, that's what you start off as your clinical criteria. And then we'll go to our lab criteria. So if that's fulfilled, and then we look at our lab criteria, do we have any supportive lab criteria or confirmatory lab criteria? So if we talk supportive, we talk about our MAT titer in 1 serum. If the MAT titer is elevated in both and the convalescent titer is 4-fold further increased, then that's a confirmation of it, but we'll talk to it in a minute. We talk about IgM antibodies. We talk about PCR in urine and then microscopy and PCR in blood. I'm sorry, I think somebody put their hand up to ask me a question. Can't see who though. It just flagged up. Do you want to speak? Not for the moment. If you've got a question, I'm more than happy for you to speak up. Otherwise, I'll just keep talking, but interrupt me if it's about this. Now, just before we go through different tests, let's recapitulate just a little time frame so we can understand when to run what test and when it is likely to be positive or when you might get false negative. So we're starting infections happening here. We've been exposed and now we get an incubation period. Okay. And that can be, as we said, I mean, we said up to 2 weeks, some people, this is up to 20 days. So after a period, your leptospira in your blood are going to be present. So you get this bacteremic phase. And then eventually, by week 1, that's going to reduce. By the time that reduces, your leptospira have gone out of your blood, but they haven't disappeared. They've gone into your organs. So you could take organ samples and test them for that, but the most common test we're going to run is the urine. Okay. So at that point, the leptospira are getting in your kidneys and you're going to start having urine shedding. That will last for a few weeks, and depending what we treat them with, obviously these are non-treated dogs, that is going to decrease. And in dogs that clear it, that might go completely down. In dogs, often you might get a carrier state and just get persistent intermittent shedding. Now, when you look at your antibodies, these are unvaccinated dogs. Your antibodies, it will take a while before you get your bacteria coming in, starting to go through the blood and things there for your antibodies to start rising. So IgM will generally start rising quicker, but will go back down. So we'll find that within week 2, week 3, and then IgG will come up and stay up really, and that is your long-term immunity. Okay. Now, if you look at a test, at this point, we could detect the Leptospira in our blood. So we can do a blood culture, although it can take long to grow them in culture. So that is generally not something that we do. Or your PCR could be positive at this point in your blood. From here onwards, your PCR could be positive in your urine till this shedding level starts dropping. And we need antibodies to be present to have your MAT test or your SNAP test to be positive. Okay. Let's talk through them separately. So the MAT test is the microagglutination titer. So what they do is they test the titer of your serum and how many antibodies there are. So often the labs will test against 6 or 7 serovars, and hopefully your local lab will test against the serovars that are prevalent in the area that you live, because this varies from location to location. But the more they test against different serovars, the more likely they're going to find the one that you want, although there is some cross reaction. So don't always say it's definitely this one. What you're looking for is a positive test. Okay. Now, the initial serum sample will often be negative or have low titers in the first week. If there are high titers in the first week, then you have one of the other things potentially. You want to check if they've been recently vaccinated, because that could be the reason. They could have had recent subclinical exposure to lepto, but went through it and it hasn't been a problem. But this is why my antibodies are now still high. Or it's been a longer duration of illness, and we're not in that first 2 weeks. Okay. Ren, can you mute yourself? Thank you. What we then want to do is you want to take what we call a convalescent titer. Okay, and we want to do that at least 7 to 14 days later. In some dogs, it might take a little bit longer, but that's what we're generally talking about, 7 to 14 days after the first one. And if I go back to the first slide, so even if you had a high antibody titer from your vaccination, after 7 to 14 days, you're going to get this massive increase if it's an infection causing it, okay? So what you want to have a fourfold change in the titer to be confirmative of infection. Okay. Now we know that these titers can persist for at least 1 year after infection. Post-vaccination titers can persist for that period, but they're going to start decreasing after 4 months. Okay. Unless you got high exposure in the environment. So a vaccinated dog that is doing very well because it's got those antibodies, but keeps getting reinfected, keeps killing it off, that antibody titer will stay quite high. Okay. Now, in some countries, there are some point of care, those lateral flow tests that you can use, which everybody recognizes because we've all been using those with COVID. Obviously, we're still looking for antibodies, so it still has the same limitations. You can still get a false negative if you test early, so don't rule it out on a single sample. Although it should be highly sensitive if you wait that bit longer, if you can, but obviously that's not necessarily helpful in the initial stage. Okay. And we know that if you get a positive sample in a non-vaccinated dog, the same as with the MAT samples, if they're non-vaccinated, then that has a very high specificity for disease. Okay. But you can get false positives with vaccination. So there's 2 brands on the market. There's the IDEX one and there's the Zoetis one. Then the second part of the testing is actually looking for the DNA of the bacteria. Okay. In the ideal world, you want to take your samples before you give them any antibiotics, because that is most likely to find them. And you want to check on blood and urine. Now, blood sample, don't do it on heparin because it affects your sample. You want to do it on EDTA, but you want to do it on blood and urine together because, again, the one go down and it'll become negative. Hopefully the other one will pick up. So you want to test them both if you can, okay? Because that is your most likely positive sample. Now, Your sensitivity, which means if you get a negative sample that is a true negative, is still variable on blood and urine and depending on the time that you're checking it. But your specificity, if you get a positive one, this will only happen if you've got bacteria in either your blood or your urine. So that does not happen after vaccination. So that gives you a 100% answer. Okay. The one thing is with storing, so you need to store urine in the fridge for a maximum of 3 days, and you can store blood in the fridge for up to 2 weeks. You can store them in the freezer for a little bit longer, but they shouldn't be constantly defrosted and refrozen for the test to be valid. Okay. And again, I mean, just getting a positive sample in a non-symptomatic dog or cat might mean that they had a previous infection, might mean that they are carriers, ongoing carriers, but doesn't necessarily mean that that is the cause of your problem. So that on its own, if you don't have any symptoms, does not mean that that is a diagnostic answer on the problem you're dealing with that day. Okay. Treatment options. I think your treatments will really depend on how does this patient present and how poorly it is. And some of these patients are incredibly poorly. Okay, as we said, I mean, if they're going an acute kidney injury, and we're not going to talk about acute kidney injury at this point in detail, but those things need specific care. So we need to be conscientious about our fluid therapy, make sure that we monitor the urine output. These dogs need lots of monitoring their blood pressure, see what their jaundice is doing. We need to give them nutritional support. We'll be weighing these patients quite frequently. Obviously, there is the issue with trying to make sure health and safety wise, which we will go through for the people that are handling them. But then the second part of the treatment by the supportive treatment is giving them the appropriate antibiotics. So the main antibiotic that we use to try and stop the carrier state they're happening as well, and the shedding is doxycycline, which generally is given 5 mg per kg twice a day for 2 weeks, or you can give the double dose, so 10 mg per kg once a day for 2 weeks. That will do it as well. For the dogs that are too sick to have doxycycline because they keep vomiting and can't have that, we can start them with IV penicillin, be it ampicillin or potentially amoxicillin. And you want to give it 3 to 4 times a day. Okay. But that is the main reason to give the penicillin. Once they then stop vomiting and they're eating okay, you still want to change them to the doxycycline because the penicillin doesn't stop the carrier state of the kidneys. Okay. So it stops the proliferation, but it can still retain them in the kidneys. So you still want to give the doxycycline afterwards. With the IV drugs, definitely the penicillins. If you have a creatinine that is markedly elevated, then you want to reduce your frequency, and you want to do it at least twice as long in between doses than what you were doing before. So we spoke a bit about the supportive care that is very dog dependent and depending what problems they have, but these often become intensive care patients, definitely the unvaccinated patients. The vaccinated patients that are maybe where it's wearing off, they tend to do an awful lot better than the non-vaccinated patients by the time we see them. So when people look at the prognosis, I think prognosis very much negative prognostic factors is a marked hyperbilirubinemia, but it doesn't have to be that high to be significant. That's a negative prognostic factor. Hypocoagulability, dogs going into DIC potentially, and the pulmonary hemorrhagic syndrome. They're all bad prognostic factors. So public health implications. We know this is a zoonotic disease. We know that there's a low risk, but there's still a risk for transmission from sick animals to people, mainly through the urine. And again, it comes through your skin that isn't intact or through mucosa. So shielding of your face, wearing gloves and an apron or doing it should be sufficient. Making sure that these dogs urinate in an area where it can't be soaked up in the ground and that's easy to wash down. Don't change their kennels from one to the other. Disinfect their kennels properly. They're all important things there, really. They should all be, to a degree from that point, barriered up to the point that they receive 48 hours of doxycycline. Okay. So even although the penicillin will work against the multiplication, it won't completely stop the shedding. And then you want to protect aerosolization of the urine. So if you're emptying urine bags or catheters, that is definitely a time that you want to be shielded from it. So what to do with the people when they take their dog back home, or the people where the dogs come from that have lepto? So what do we know? As we said, we went through that chart. So urine shedding doesn't happen for the first 7 to 10 days post-infection. Okay, might even be longer with that incubation period, but that's what we're working towards. So most often these dogs wouldn't have shed any lepto in the house. Okay, so you can give them that bit of support. If the dog then goes back home after you had them in the hospital, again, the owner needs to protect themselves quite carefully till 48 hours into the doxycycline treatment. So depending when you send these dogs home. And we probably would recommend treating prophylactically the dogs in the household, as they, not necessarily because they've been in contact with that dog, but because they've been sharing the same environment outside. Therefore, they've probably been exposed as well. What we do with cats for the moment is still a little bit unclear, because there's certain studies that found that maybe up to 20% of cats, asymptomatic cats, might be shedding lepto. But then when they looked at the cats that roam free, certain studies didn't find any cats that were shedding them. Obviously, there's the intermittent shedding and everything there. There's currently no real guidelines as should you be treating the cats as well. You could be testing them and urine testing them. You probably need to do it for a few days to be sure there, really. But there's no clear guidelines of what is the right thing to do with these cats yet. Now, before we all start putting our cats to sleep, because there might be a risk for spreading lepto, we definitely know that cats are more likely to be carriers and not show signs, but that in areas where cats were present, even if they had, some of them had lepto shedding, it was still less likely that people presented with lepto because the cats controlled the rodents, if you see what I mean. So the whole infectious load was still lower. I think that's the end of my talk. Before we go to questions, I just wanted to mention to you guys that I've been working on a 4-week anemia talk. So we're going to talk a little bit through the principles, in-house testing of anemia. Then we'll have a day or a couple of hours about non-regenerative anemia, talk more about hemolytic anemia, and then a little bit about transfusion in practice and what can you do, what is an easy way of doing, and when should you transfuse, what should you be thinking about. We'll have that up and running over the next few weeks. If you want to sign up to the waiting list, then either follow the link or I can't. Or scan the QR code, and then we'll go from there. Next week, the plan was to go back over how to get the most out of your vet consult and talk half an hour about that. Very happy. But then after, if people have other subjects that they want to have reviewed over half an hour, to take your thoughts and your ideas, if you send them to me, we can talk through them. At this point, I'm going to stop sharing and see if people want to share their experiences or if they have any questions that I can try and answer or find more information out for you guys as we did after the FIP. So thank you all for listening. Mohammed, do you want to share your question?
Yes, ma'am. I have a question. About the treatment plan, we use doxycycline for leptospirosis as far as there's no complication regarding liver. Why is it so? And first of all, if the patient has reached the problem has reached in its liver, so there is a contradiction according to court clinical advisory. I have read that we can't use doxycycline. Why is it so? And in instead of doxycycline, we can use penicillin and other antibiotic. So what is the reason that we can't use doxycycline in pathological liver state? Thank you so much.
Okay, are you saying am I getting it? I'm just going to repeat the question to you just to make sure that I got it right. That your guidelines are saying, your general drug guidelines, that you shouldn't use doxycycline in dogs with liver failure. Did I get that
Yes,
right?
ma'am.
So what should you do? Okay. Well, I would still say, obviously, I think there's a difference between chronic liver failure and acute liver failure. And you are right. You should be careful. Now, most of these dogs will have an acute cholestatic hepatopathy, but they won't necessarily be in liver failure. We talked about this, I think it was July. We'll repeat the talk at some point, but there is a difference between having liver damage going on and liver failure. So, liver failure means less than, probably in most cases, 20% of your liver still functioning. Liver damage is the cells are being damaged. So, your ALK your enzyme release, is liver damage. Liver failure would be low cholesterol, low glucose, I mean, harbor acids, but because you have your jaundice, you can't necessarily run those. So I would still, with these patients, till they are stable, go with the penicillins. Once you get through the stage that will decrease your liver damage or give you time to decrease your liver damage, then I would follow that up with the doxycycline. Okay. On that phase as well, Badan asks, can I give enrofloxacin? So I think, can you technically? I mean, technically you can. According to the antibiotic guidelines, enrofloxacin should not be the first drug that we're giving. So if it was resistant to other drugs, it has been shown to clear carrier state in a population of animals that they checked in a recent study, but it's not my first drug of choice because we have a very good alternative. And obviously, according to the antibiotic resistance issue, we shouldn't really be using enrofloxacin when there's a different drug available. Baziliki asked me why or how is thrombocytopenia explained in these patients? Is there specific mechanisms? There's several mechanisms that might be contributing to it. So I think one will be consumption. So these spiral sheets, they damage the vascular wall, which they cause the leaking of blood and therefore and some vasculitis, which will cause your thrombocytopenia partially there as well as an initial stage. There are some initiations maybe that there could be an immune-mediated irritation there as well. But the main thing is, I think, is either consumption or the vasculitis. So they shred it against the vessel walls. And they've been used to try and block those holes off. Ahmad, the recording will be available. I mean, I'm still recording now, so we get all the questions in there as well, and it will be available, so we can send that out to you. Ayub, what question would you like to ask? Are you there?
Hello?
Hello, you're there. You're back.
You got my voice? Can you hear me?
I can hear you.
Thank you for... Oh, there's another one. I don't know.
Yeah, Nick, I can hear you as well. Could you mute yourself? Let me see. I'll mute Nick for you. Let me see that you're still unmuted. I can see you. Ayub, you still there?
Yeah, I'm here. Yeah, hello,
Fine.
hello. Thanks
Try
for
again.
yeah, hello. Thanks for your presentation. Unfortunately, I had a patient. I had to go for minutes. I just came back and I wanted to ask the question. So I don't know about Europe and UK or US, but for the Leptospirosis serovars, in the vaccines, which gives protection, what is your point? What is your notion for the maximum protection? Because as I remember, there was no evidence of approved cross protection for serovar. So there are many types of vaccines, like those with 7, those with 8, or those with 9. I don't know what it's like in your country. Like the one is like protecting one serovar, and the one is like 3 to 4, which gives protection. So how do you see it? And how do you use vaccines there? I mean,
yeah, we do use vaccines. Let me just see, because I did think I had a slide on that, but I don't know where it's gone. we do. So we used to have the vaccine. Oh, I have. Okay, that's fine. We used to have the L2 vaccine, which but that has recently, we now have an L4 vaccine as well, so it has 4 serovars in it. The recommendation definitely around here is use the L4. And I would say the cases that we clinically see are either not vaccinated or had the L2 vaccine. Because the L4, obviously, there's 4 serovars in there, which are the 4 more common ones. I guess they're definitely looking in, does this need updated? And certain areas you might still will have exposure to serovars that aren't included and there's no cross reaction with it. But definitely the patients we see, I would say 99% of the patients we will see with clinical disease and it's a referral hospital, will be patients that had either no vaccine or not updated vaccines or an L2 vaccine. So I would say, I mean, one, in your area, check what your vaccines that you have available, what serovars they got in them. And then if you either find any papers or contact the lab in your area to ask them what leptospirosis do we see, then you can almost cross-match, is it worth going for the more expensive vaccine or not? But I would generally say the more serovars you can vaccinate against, the less your risk will be to get clinical disease. I hope that helps.
Thank you. Yeah, you even answered my second question. So yeah, thanks for it.
You're welcome.
So one thing you recommend to we should pay attention to those serovars which are like kind of pandemic in our areas, and choose the L4. I mean vaccines to give the maximum protection. Yeah.
Yes, absolutely. I think definitely the L4 will contain most of the serovars we will see. There's definitely one that definitely when I look at the UK, that the Sergio that we see infection with, maybe on the other side of the country, although the country isn't that big, that isn't in the L4, but all the other ones are covered by the L4.
So Dr. Nere, one more question. As I remember, the new vaccination guideline in Europe, this one I remember, vaccination for Leptospira was suggested to be done like after 12 weeks, like 3 or 4 years ago. But as I remember, the newest guideline, the update one, suggested like you can start it from the 2nd month, like from the 8th weeks, you can do it. Do you have any idea about this, like what we should do?
So, I mean, obviously I do very little vaccinations, but yes, I think you can start them earlier. The reason they say to continue it past the 12 weeks is because of your maternal antibody. So even if you give them at 8 weeks, they still recommend you then give them at 12 weeks and then again 4 weeks later. Okay. Or you start them at 12 weeks and then 16 weeks. But it's more the when do you stop them with the maternal antibodies that I believe is relevant rather than when do you start them. Okay, but a lot of people want to start them early because they want to let the dog out early and go and take them for a walk. So that's why they want to start them early. But because it still interferes with maternal antibodies at that point, they're less likely to build up their own antibodies. Does that make sense? So that's why you want to do it again at 12 weeks and at 16 weeks when those maternal antibodies, it's variable when they start weaning off, but when they're less likely to be interfering with you build or the dog building up its own immunity. Amir asked me, have I ever come across an L4 vaccine site reaction? I think we come across any vaccine site reactions. I'm just checking if I haven't gotten anybody else. Any vaccine can give some reaction. When they looked at the complications they had after the L4 vaccine compared with the L2 or other vaccines, they weren't significantly more frequent than with the other vaccines. But obviously, any vaccine you're given for an antibody can give you a reaction, be it locally or be it a poorly dog. And you said, what did you say? I mean, I have seen one dog vaccinated, but I've seen if it had primary cause, but we didn't know where it was. Or the vaccine reaction, yeah, I think it's impossible to know which one it is, isn't it? Tiago, is there any particular serovar more prone to cause pulmonary hemorrhagic syndrome? No. So when people started looking and can we associate any of the presentations to any of the serovars, it is very variable. But the serovars don't seem to be a consistent feature. What is causing what issue? Ahmad, I still think you got your hand up. I think I've gone through the chat. Do you want to ask anything?
Yes, doctor, I wanted to ask if there a pet dog or any dog is affected with leptospira and recovered, should we vaccinate him or her again?
Sorry, said it again. If every dog that's affected with leptospirosis,
Should we vaccinate him after the recovery or not?
yes, absolutely. You should vaccinate them. I mean, this dog, if this dog has been exposed to lepto, I wouldn't do it straight away when they're poorly. But once they're recovered, the recommendation is to vaccinate them as soon as they recovered clinically well. Obviously, it might take them a while to get completely recovered, but as soon as they're well enough to have otherwise a vaccination, that their immune system is not struggling with an acute infection, the advice is to go and vaccinate them because these animals will be prone to get potentially through contact because if they've been exposed to it, they might only have this variant this time, but they could get another one. So the recommendation is to have them vaccinated.
Okay, thank you so much.
You're welcome. Basilika, you got your hand up?
Hello, thank you for the wonderful presentation. I've got one question. You said that as a precaution measurement, we should treat other dogs in the household if a dog has already leptospirosis. What about cats in the household?
Wow, that's a bit. I think there's
Because
not
I'm a bit scared about,
consistent.
Doxycycline and
Yeah,
the stenosis
agreed.
esophageal strictures and everything, just as a
Yeah.
precaution.
There's no current recommendations on doing the cats as well. So, I mean, I would probably, what I probably would advise is get them to bring, if they can, if the cat urinates inside, get a few days urine from the cat just in one pot, and that you go and PCR it
And
just to
PCR.
see if it's excreting it. Agreed, I probably wouldn't prophylactically treat every cat in the household because, or they'll have to be very good care of how and making sure that they give it either with food or give water afterwards. But yeah, I've seen the strictures as well, and they're not pleasant. So
Yeah, I know. And
um,
as a gastroenterologist, we encounter not many cases, but we have encountered cases with intussusception and hemorrhagic diarrheas. And it was lepto, and I'm always
yeah,
aware of that. So I inform my team about that. And another question, very short one, because I know that we've kept you longer
that's all right.
than we should. What about the pulmonary, the acute pulmonary hemorrhagic syndrome? Could
Yeah.
it be the sole manifestation or the initial manifestation without any other, renal or liver damage up front
Well, they
in the
often come,
beginning?
yeah, they very rarely will come just with the pulmonary changes. They often will still have the other blood changes as well because it is a severe disease marker. So these are often dogs that you might already have in hospital because of lepto, because of another problem, but that these dogs will develop this syndrome. And if they do, I mean, as with any bleeding into the lungs of dogs, it's not really a benign
Yeah. Thank you.
event. So yeah,
Thank you
thank you for
very
your
much.
question, though.
Thank you.
Anybody else? Nobody, it seems. Well, thank you so much, everybody, for your questions, because it always makes it far more fun for me to talk, at least to people. It's still to a screen, but have some interaction. So thank you so much. Enjoy your Wednesday afternoon or evening, and hopefully I'll see some of you next week or one of the next few. Thank you all. Bye-bye.